Hello everyone, Dr. Prashant Menon. I'm a consultant neuroanesthesiologist. Today I'll be talking about epilepsy surgeries. The surgical treatment of epilepsy is considered in the small subset of epilepsy patients. The anesthetic and surgical considerations here are intertwined. So understanding these unique implications may help in tailoring the anesthetic procedures for the smooth conduct of these surgeries. It may also affect the overall outcomes in these surgeries. So this presentation is an attempt to give an overview on the subject. Start with a brief history. So in the 19th century, Ernst and Dudley brought in this concept of surgeries for epilepsy. Victor Horsley introduced the modern epilepsy surgeries. Forrester and Penfield in 1930 were considered as pioneers in electrophysiological brain mapping, were the first who preferred sedation only after the initial electrical stimulation testing of the brain. In 1954, Jasper considered epilepsy surgeries for post-traumatic and post-infectious etiologies. In 1886, Horsley brought the concept of awake craniotomies with local anesthesia. Davidoff took this step further higher, the combination of local anesthesia and sedation. Pasquet employed complete general anesthesia after the initial electrophysiological testing of the brain. Now, what are seizures? So seizures are time-limited paroxysmal events that result from abnormal, involuntary rhythmic neuronal discharges in the brain. So seizures are usually unpredictable. They strike out of the blue, and they are usually brief, lasting less than 5 minutes and stop spontaneously. They are also referred to as convulsions, ictus, events, spells, attacks, or fits. Epilepsy, on the other hand, is a disease which is characterized by spontaneous recurrence of unprovoked seizures, and by definition, at least two seizure episodes are required to diagnose epilepsy. While seizures are symptoms, epilepsy is a disease. So, ideally, these two terms should not be interchangeably used. So, epilepsy may be considered as a seizure disorder and it is often syndromic. So, who are the candidates for epilepsy surgery? For patients with persistent seizures despite adequate, appropriate pharmacological treatment with impairment in the quality of life due to these ongoing seizures are candidates for surgeries. So this brings into focus the concept of medically intractable seizures, which is previously referred to as pharmacologically refractory seizures. So these are patients who are not responding well to medical treatment, and most experts agree that if a patient fails an adequate trial of two anti-epileptic drugs for a reasonable period of time, his or her epilepsy may be considered as intractable, and about 25 to 30% of epilepsy patients may be categorized into these groups. So in these patients, the conventional anti-epileptic therapy should be continued while other options are sought to control the seizures. So the pre-surgical evaluation for these surgeries includes a thorough history and examination. A structural scan in the form of an MRI may be used to identify possible or potential seizure foci in the brain. For example, in a mesial temporal sclerosis, you could find a hippocampal sclerosis, or you might find a tumor or vascular malformation or cortical dysplasia, which would potentially be the site of this seizure onset. Electrophysiological studies in the form of scalp EEG may be used to assess the ictal and interictal epileptiform discharges from the cortex. So this helps in defining the semiology and the focus of the seizure. And if required, multiple electrodes may be used to get a detailed study. Functional imaging in the form of a PET scan or a SPECT scan may also be used to define the seizure focus. Other tests in the form of a neuropsychological testing may be done preoperatively to assess the baseline function of the patient, and it also will corroborate with other findings and helps in further localizing the seizure focus. And it also helps in predicting the risk of cognitive decline after the surgery. WADA test or intracarotid amobarbital test is considered as a gold standard to assess the lateralization of memory and language, and it also helps in assessing the predicting the postoperative decline of these functions after surgery. Magnetoencephalography or MEC may also be used to assess the intrarectal epileptiform discharges and also to map the cortices, eloquent cortices like motor and speech of the brain. So, what are the key considerations in epilepsy surgery? Now, is there a structural lesion which can be the potential focus? And if so, if the electrophysiological testing and the functional imaging also corroborates these findings, and if so, are these two findings concordant? Once you have a location, then you have to look if the relation of this location with the significant or important parts of the brain or eloquent cortex, and if these foci are multiple, single, bilateral, or unilateral. The pre-anesthetic evaluation of these patients primarily focuses on four important things. That is the primary disease, that is the epilepsy or the epilepsy syndrome itself, associated comorbid diseases as for any other surgical case, airway assessment, and also special surgical consideration in these patients. So when we look at epilepsy itself, you focus on the duration diagnosis and the drugs. Most of the epilepsy syndromes are associated with other system abnormalities like endocrine abnormalities, cardiac and liver abnormalities, airway difficulties, renal and drug interactions, gastrointestinal abnormalities, and coagulation defects. The anti-epileptics also comes with a wide range of adverse effects like tremors, gingival hypertrophy, nausea, weight gain, anorexia, electrolyte imbalances, cognitive disturbances, depression, lethargy, anemia, and thrombocytopenia. The drugs may also have adverse interactions. Most of the anti-epileptics may have an enzyme induction function, so they could potentially accelerate the metabolism of most of our induction agents. It may also translate into increased dose requirements of muscle relaxants when needed, and also potentially increase the risk of renal and hepatic injury due to the metabolism of volatile agents. The surgical considerations in these patients that are very important in tailoring the anesthetic techniques include when and where you actually encounter these patients. So you might encounter these patients for a diagnostic electrode placement or other kind of diagnostic modalities like a WADA test, radiological diagnosis, or MRI. You could directly be seeing these patients in the OR for a surgical or palliative resection or disconnection of the seizure focus. Or you could be encountering these patients for an extracranial neuromodulatory procedure. Occasionally, an invasive electrode may be required to further define. This is considered when the localization and lateralization are not well defined, or there is excess artifact on the scalp electrodes, and if the suspected seizure focus is very close to functional eloquent areas, and if there are multiple intracranial lesions. Three types of electrodes may be used: a strip electrode, which is a linear array of 12 to 16 disc electrode embedded in a strip of stylistic material, or a grid electrode, which has multiple contact points up to 64, and depth electrodes, which are more invasive, which are multi-contact thin tubular rigid or semi-rigid electrodes which penetrate the brain and allow for recording the deeper structures. So anesthesia management for an electrode placement depends on what kind of electrode is being placed. So for a depth electrode and a strip electrode, a burr hole may be sufficient, whereas for a grid electrode placement, a complete craniotomy and durotomy is required. However, in these procedures, ECOG is not routinely recorded. The complications of the electrode implantation includes infection, transient neurological deficits, hematomas, and cerebral edema, particularly with the grid implantation. And with the more invasive depth electrodes, you could have intraparenchymal or subarachnoid hemorrhage, misplacement of the electrodes, and accidental injury to the posterior cerebral artery and the brainstem. Now, what are the surgical procedures that can be used in epilepsies? These can be broadly classified into three types. The resective surgeries, where you have a definite seizure focus and it is far away from the eloquent cortex so that you can comfortably resect it without causing any significant neurological damage. Where this is not possible if you have multiple foci or a very large area of the brain, or the focus is very close to the eloquent cortex, the idea is to actually reduce the number of seizures and also prevent complications associated with generalization of seizures like drop attacks. And also at times to remove dysfunctional cortical tissues which are not actually contributing to any neurological function. So these include disconnective procedures like corpus callosotomy, hemispherectomy, both functional and anatomical, and of course, multiple subpale transections. And both these types of surgeries are not possible, then other techniques like neuromodulatory procedures, deep brain stimulation, responsive neurostimulation, and gamma knife, and vagus nerve stimulations may be used to control seizures. Surgical modalities which are resective may include lesionectomy when a focal lesion is found with a single epileptogenic zone, or a temporal lobectomy for a temporal lobe epilepsy, selective amygdala hippocampectomy primarily for a hippocampal sclerosis, and tailored neocortical resections. Disconnective procedures like hemispherectomy or hemispherotomy, multiple subpale transection, and total or anterior posterior corpus callosotomy are all used as disconnective and palliative procedures. What is the choice of anesthesia in these surgeries? So it depends primarily on the institutional practice, the patient preferences, and the profile of the patient also, the expertise and the confidence of the anesthesiologist, and the specific neurophysiological monitors that are being used intraoperatively. So all the methods like local, monitored anesthesia care, and GA have been successfully used in these kind of surgeries. When you're considering general anesthesia, some of the important considerations are to avoid pre-medications like benzodiazepines, which are potent anticonvulsants that could potentially interfere with the ECOG monitoring during the intraoperative period. The dose of anti-epileptics to be given to the patient is based on the institutional practice and a consensus reached on whether to continue the full dose or to completely avoid the dose. Induction is usually with an ultra short acting agent. Maintenance phase would depend on whether an ECOG and brain mapping modality is being used, and when a brain mapping modality like motor evokpotential is used, volatiles and muscle relaxants should be potentially avoided. Drugs interfering with ECOG and brain mapping modalities should be preferably avoided. So this slide shows the drugs and their effects on the various modalities. The propofol, which is the commonly used drug, has minimal effect, while volatile agents and the conventional induction agents have significant effects on all the three modalities. Awake craniotomy is another option, where the advantage is that there is no effect on any of these monitoring modalities, and it is useful when you are operating near eloquent areas like speech and motor areas. The anesthetic goals in an awake craniotomy would be to minimize the patient discomfort and ensure patient responsiveness and compliance with minimal inhibition of the seizure activity, and at the same time make the operation safe and effective and reducing the psychosocial distress of the patient. Awake craniotomy can be done in various ways. Purely a local anesthetic based technique is not usually preferred, but a monitored anesthesia care with some amount of sedation with local anesthetic is commonly used. But more commonly, the AAA technique or the asleep technique is preferred by most anesthetists. Monitored anesthesia care techniques is actually defined by ASA as a specific anesthetic protocol that includes careful monitoring and support of vital functions. And here, the anesthetist administers sedatives and analgesic and, if required, a hypnotic, and addresses any clinical problems and provides the patient with psychological support during the procedure. The ASA recommends that the provider of MAC should be prepared and qualified to convert to a general anesthesia if necessary. The pre-anesthetic evaluation would include an emergency airway plan with a thorough airway assessment, and special emphasis should be given to the positioning with emphasis on spine, cardiac and respiratory pathologies, postnasal and trip and cough, bladder and bowel problems, psychiatric condition of the patient and the age of the patient with motor symptoms. And the focus should also be on the various drugs that are being used and the potential hypersensitivity or allergic reactions to these drugs. A proper pre-op counseling explaining about the procedure, the monitoring protocol, and the cortical mapping, anticipated problems and the safety measures that are in place, and also the unusual sounds that the patient could encounter due to the monitors drilling, and also points or timelines in the surgery where the patient could have discomfort. This could actually be mitigated by a pre-operative visit of the patient to the theater to reduce the anxiety levels. Pre-medications in the form of benzodiazepines is preferably avoided. Antiepileptics form a very important part of the pre-medication. Antipsychotics is again controversial, and it is preferably avoided considering that a dry mouth is always uncomfortable to a conscious patient. Fasting guidelines is for as any other general anesthetic procedure, and the decision to continue antiepileptics is based on the consensus between the surgeon, anesthetic, and the physician. And the operating room should be organized in such a way that the anesthesia machine, airway devices, and emergency drugs are easily available. The room temperature should be set in such a way that the patient is comfortable, and the surgical table should be covered with soft and thick dressings. And the surgical team should be instructed to speak and move very slowly and to avoid unnecessary conversations. Study the position of the instruments to minimize the unnecessary movements. Patient should be positioned comfortably with soft mattresses. Both lateral and supine positions have been used for awake craniotomies. Adequate lighting and light music may also be helpful. So this is an image showing a patient positioned in lateral, the head pins on for an awake craniotomy. The patient's face should be positioned in such a way that it allows him or her to look at the anesthetist and at pictures and can obey commands during the brain mapping procedure. And this also ensures that the airway is accessible during emergencies. An audio video recorder, if available, should be used so that the surgeon can also be able to hear the patient's responses. So this is a drape where you can see that the patient's face is clearly visible when the surgeon operates on the skull. Analgesia is usually provided with scalp block, ring block, pin site infiltration, and other supplementary methods. So scalp block forms the basis of an lay or MAC based awake craniotomy. Contraindications are minimal, like hypersensitivity to the local anesthetic or an absolute patient refusal. The relative contraindications include bleeding tendencies and recent craniotomies. Drugs used include lignocaine, bupivacaine, or ropivacaine, both in combinations or singly. Additives like epinephrine, sodium bicarbonate, and hyaluronate base may help in a uniform spread. So in scalp block, you block supraorbital, supratrochlear, zygomaticotemporal, auriculotemporal, lesser and greater occipital nerves on both sides because there's some amount of overlap. So these are basically derived from the cervical spinal nerves and trigeminal nerves. At times, the scalp block may be patchy, so you can always supplement it with a ring block or a superficial cervical plexus block, and additionally a pin site infiltration. So this image shows the schematic diagram of the potential landmark for a superficial cervical plexus block. Complications of scalp block include pain tissue irritation, discomfort, and local hematoma, infection, local nerve lacerations, local anesthetic toxicity, and hypersensitivity reaction. Sometimes the patient could have intracranial pain after the craniotomy, and this is probably due to the dural structures, which are mostly insensitive except at sites of vascular structures piercing. And paradoxically, insula could have some amount of pain sensitivity. Vascular structures and lobes, when they are distracted or moved, can incite pain and vomiting. So whenever there is a breakthrough pain, we might have to supplement additional analgesia. Sedation may be used in combination with the scalp block. So the drugs that we use should be easily titratable. Minimal effects on the monitoring modalities of ECOG and SSEP-MEP, minimal respiratory and hemodynamic instability and complications. Propofol is the commonest drug that is used. So it has a three-compartment model of pharmacokinetic, which is usually favorable and can be used both as a TIVA, the 2 to 3 mg per kg per hour infusion, or as a TCA protocol with an effect site concentration of 1 to 2 micrograms per ml. And propofol has minimal suppressive effect on the ECOG and the mapping modalities if it is stopped well in advance, at least 15 to 30 minutes before the planned monitoring. The advantage of propofol is that it has minimal suppression of the ECOG, and additionally it has got antiemetic, anticonvulsant properties and may have favorable effects on the CMRO2 and the ICP. And the induction and recovery is relatively smooth. The disadvantages are that it can potentially cause respiratory cardiac depression with hemodynamic instability, and it has absolutely no analgesia, so a supplemental analgesia should be continued. And it can leave some residual footprints like large beta activity. Remifentanil is another wonder drug which can be used as intravenous analgesia in sedation in spontaneously bleeding patients. It has got a very good pharmacokinetic profile, and it is minimally affected by the extremes of age or renal or hepatic dysfunction. And its effects can be rapidly titrated, and it dissipates rapidly after discontinuation. It can be used as a TIVA of 0.05 to 0.1 microgram per kg per minute infusion, or a TCA protocol with an effect site concentration of 1 to 3 nanograms per ml. In the Indian context, dexmedetomidine is the wonder drug which is very commonly used in these kinds of awake craniotomies. So it is a highly selective alpha-2 agonist, and it has a dose-dependent sedative, anxiolytic, and analgesic effect with no significant ventilatory depression. So it can be used with a loading dose or without a loading dose. If used with the loading, it is given at dose of 1 microgram per kg over 10 minutes, and then an infusion of 0.2 to 0.8 micrograms per kg per hour infusion. So it acts by inhibiting norepinephrine release at the locus coeruleus, and it is very similar to clonidine. However, it has a very high affinity to the alpha-2 receptors with a very short half-life. Other drugs like neuroleptics, droperidol, and fentanyl have also been used. Intraoperative monitoring would include an ECG, non-invasive blood pressure, pulse oximetry, respiration and capnography, body temperature, and an assessment and quantification of sedation by a sedation score. Invasive BP may be considered wherever required. Urinary catheterization is again controversial, but wherever it is necessary, it should be done either by a conventional Foley's catheter or by a condom catheter. Central venous pressure may be used when you need to give large amount of fluids or when you're anticipating large fluid shifts. And bispectral index can be used as a surrogate to sedation monitoring. Some surgeons practice what is known as a provocative maneuver. It can be both pharmacological and non-pharmacological. So provocation is primarily to increase the intraepileptic seizure activity during the ECOG monitoring. Pharmacological maneuvers include administration of methotrexate, etomidate, alfentanil, tramadol, or sevoflurane to provoke a seizure activity. Non-pharmacological techniques like auditory stimulation and hyperventilation can also be used. However, many surgeons do not believe that the EEG or ECOG findings precipitated by these provocative maneuvers clearly identifies or defines the seizure focus. The patient management would include a good IV access, fluid management, and oxygenation ventilation management. Occasionally, you could have an agitated patient during the procedure, so rule out improper positioning and the full bladder, hypoxia, hypercarbia, and local anesthesia toxicity and other metabolic causes. Reassure the patient, if required, increase the level of sedation. Proper communication with the patient may solve most of these problems. The bladder fullness is the issue, consider catheterization or a condom catheter. Many patients complain of dry mouth, so using ice sip or clear sips of water may be helpful. Intraoperative seizure is a dreaded complication in these procedures. So always keep a ice cold slush ready and increase the level of sedation if the seizure is precipitated, and you might have to convert it into a general anesthesia with a definitive airway and consider loading the anti-epileptic. Airway management also poses special challenges, particularly because of the position and the requirement of special equipments and the possibility of an emergency airway intervention in these patients. Patients can have bleeding, particularly when the focus of epilepsy is very close to large vascular structures. So blood and product should be administered as required. And these patients are at risk of potential air embolism. So close monitoring and vigilance may be required. And if identified, a prompt intervention to avoid excessive air entrainment and complications should be taken. Patient can have intraoperative and postoperative nausea and vomiting, primarily because of the traction on the dura, lobes, and the vascular structures. Pre-medication and intraoperative administration of antiemetics may be helpful. Anti-ICP measures like osmotherapy and Lasix or other diuretics may be used, but due consideration should be given to the discomfort it can cause due to excessive diuresis. Patient can have pain during the course of the procedure due to the decreasing effect of the local anesthesia. This is particularly common when the procedure lasts for a longer time, and also occasionally due to intracranial pain originating from pain-sensitive structures inside the skull. So this could be countered by small doses of opioids or by repeating the block if possible. The asleep awake asleep technique is the more comfortable technique from the anesthetic and the patient's perspective. So here the patient is asleep during the craniotomy and most of the painful part of the procedure. And the patient is woken up during the corticography and the functional mapping and during the resection. And post-resection, the patient may be kept sedated or put back to sleep. So the procedure has to be explained to the patient, particularly regarding the awareness during the awake phases of the surgery. And there could be potential pain, and the exact plan of addressing this issue should also be explained to the patient. And avoidance of unnecessary movements wherever possible, and the monitoring protocol should be explained to the patient. Pre-medications should be given, anti-epileptics should be continued as per the consensus and the protocol of the institution, and other pre-medications like anti-secretory, antiemetics, and antacids should be continued. Consider a GA initially with drugs that could have minimal effect on the monitoring modalities. Airway management depends on the comfort and expertise of the team. Everything from an ET tube to a supralaryngeal airway device to a cuffed nasopharyngeal airway have all been used in the initial sleep phase. Extracranial procedures are procedures that are used when both the resective and palliative procedures cannot be done in a particular epilepsy patient. So some of the commonest procedures that are done are left vagal nerve stimulation and responsive neurostimulation. Responsive neurostimulation is still in a primordial state. However, vagal stimulation has got an FDA clearance. So it is effective in 30% patients of refractory epilepsy. It is usually performed under a GA with an endotracheal tube or LMA, or occasionally under a pure superficial cervical plexus block. Potential considerations are bradycardia and hypotension during handling of the vagus nerve, accidental injury to the nerve, and bleeding and damage to the nerve or other potential complication of these procedures. So epilepsy surgeries, although have promising results when applied in appropriately selected patients, the utility is still not adequate. As I told you, that 25 to 30% of patients may be categorized into refractory or intractable epilepsy patients. Only 1% of these patients actually undergo epilepsy surgeries. And data suggests that up to 10 to 15% of these patients could potentially be candidates for these kinds of surgery. So there could be a drastic increase or improvement in the technology such that many of these patients could be considered for a surgical intervention in better management of their epilepsy. So I would like you to like, share and subscribe this channel if you like this video. Thank you.